other side of the post-pull-through problem, and that is the soiling patient. Often it's a patient that's not obstructed, not distended. They just keep soiling. So let's talk about what to do with this patient. So post-pull-through soiling, the child is 4 years of age. And what are our next steps? Let's go to the next slide.
They had standard rectosigmoid disease.
Yeah, all of these, this is all standard rectosigmoid disease, had a pull-through, and the pull-through was done well. And let's see what everybody thinks. So Jack mentioned the algorithm for the obstructed patient that is an APSA initiative published. There is now a algorithm for the soiling patient that's in publication, and I can show that at the end. Okay, so Megan?
Me again?
You have a
Megan.
four-year-old in your clinic,
Yeah.
and they're soiling.
So I think you have to figure out the mechanism of their incontinence, if this is true incontinence or pseudo-incontinence. So you need to see if this is overflow incontinence from a kid who's been chronically obstructed, or if this is a sphincter problem, injury to the sphincters, lack of the dentate line, to help you make your decision. And so I think this is another situation where we're thinking about all of the above may be appropriate in that patient, depending on their background.
Except I don't think I would start with Botox
I
in
wouldn't
a
start
soiling
with Botox,
patient.
I agree,
Yeah.
in a soiling patient.
All of the
So-
above except Botox.
But if I got a contrast enema that they were chronically backed up, maybe.
Yeah, so the contrast study obviously looks for anatomic
said
problems.
zero.
The examiner anesthesia and rectal biopsy we already discussed. We talked about Botox. What's the value of interrectal manometry, Jack, in this scenario?
Well, I think there's two things you can learn from anorectal manometry. The first is whether the sphincter muscles are adequate. You may find that they have had damage to their sphincter. Usually it's during the time of the pull-through, but if they have very low sphincter pressures, then that could be an explanation for the soiling. The other thing is that part of manometry is blowing up a balloon in the rectum and asking the child to tell them when they feel it. And if they have lack of sensation of a full rectum, that can also contribute to soiling. So I think manometry is very helpful.
Yeah, and just to emphasize very important words that Megan said, is you have to figure out, does this patient have potential for continence or not? And in an ARM patient, their potential for continence could be limited by things like an abnormal sacrum and an abnormal spine, even though you've done a beautiful operation. In Hirschsprung disease, all those patients should be continent. And if those patients are not continent, there may be a problem with the sphincters, i.e. they were overstretched, or the anal canal, which might have been resected if the dissection was started too low, or both. And those patients, unfortunately, will be incontinent and need a bowel management mechanical program. But if the anal canal and the sphincters are good, and we use anorectal manometry to confirm that, but you can pretty much look on physical exam, and if the anus is closed, their sphincters are good, and if it's wide open, the sphincters are potentially injured. But if the anal canal and the sphincters are good, then we have medical management ahead of us, which we're going to get into. Okay, so let's delve into this now. So what has happened here? These are two different patients that are soiling. Take a look at these pictures. And now let's go to the question. So, Tim, what do you see?
So on the picture on the left, that anus looks like it's patulous. So that possibly could be like an injured sphincter or something that was overstretched during the initial operation. The one with the Lone Star in, I don't really see a dentate line in that as well. So these are probably kids that would then fall into that possible category of true incontinence, and then would probably head down to another pathway than the child for the pseudo-incontinence. But I think back to the pseudo-incontinence, just one quick thing about like the obstructive symptoms. I think sometimes after you get these kids to fully empty, we've been putting them into like psychology as well as physical therapy. because it almost seems like they have to almost relearn the way to kind of sense when they need to stool because they've been obstructed and soiling for so long, and we found that to also be helpful. So if you have those resources available at your institutions, those are also can be an adjunct to what you would normally do, like from a medical management or surgical standpoint.
So, yeah, so those are both unfortunate postoperative problems that were potentially preventable. All right, so now let's talk a little bit about these two patients. So this patient has been found to have intact sphincters, an intact dentate line, and is soiling. What would be your treatment? Let's go to the questions. Now, again, no obstruction, no distension, no enterocolitis, normal sphincters, normal dentate line, and the patient is soiling. What would be your treatment plan? Megan, you want to take this one?
Obviously, if they're still stooling and everything's still intact, they are not able to control what's coming through. And with their colon moving that fast, manometry could be helpful, but for medical
Why
treatment.
do you say the colon is moving that fast?
If they are an intact child of toilet training age and they cannot make it to the bathroom and they're not obstructed with stool and it's not overflowing,
Right.
then they're not actually able to make the sensation, the connection that they have to go to the bathroom and get there on time. So things are probably just moving a little too fast for them to actually manage.
Yeah, so I just want to make sure everyone made that same leap that Megan made, because that's what you should see in that image. Again, I made specific emphasis to the fact that this is not obstructed. A lot of people say, well, it looks like the left colon is narrow and maybe that's retained aganglionosis, and well, that's not going to be the case in a patient that's stooling with no obstruction, right? So that might look like a residual Hirschsprung's contrast study, but not in a patient who's clinically stooling with no distension and no obstruction. So this is a patient that I agree is moving too fast. So this is a patient that came to me with soiling that was on Senna. Guess what I did? Brilliant. Stopped the Senna. In 2 days, the child was perfectly continent. So the surgeon assumed that the patient has Hirschsprung's and therefore must have constipation. And that's not true. In fact, I'm amazed, actually, that more patients with Hirschsprung's in whom a rectosigmoid has been removed, why aren't more of them hypermodal? It's amazing, right? If we take out a rectosigmoid in any ARM patient, it's big trouble, right? We know that from the abdominal perineal pull-throughs of the past. Those patients have no reservoir. But a Hirschsprung's patient, they can maintain their continence. A J pouch in a ulcerative colitis patient maintain their continence despite super duper motility. Why? Because their anal canal and their sphincters are intact. So this patient is just hypermodal and needs to be slowed down, and if the move is to stop the laxatives, great, but the move could be give some Imodium and slow them down that way, or some water-soluble fiber. Try to get them to one formed stool per day, and all of a sudden you'll have a continent patient, provided the anal canal and the sphincters are okay. All right, and let's do this one. So this is, again, same scenario. Intact sphincters, intact dentate line. They are soiling. No enterocolitis, no distension. But something's different, obviously. Now let's go to the question slide. And what would you do for this patient? And I'll have Jack, you take this one.
Now, I would use stimulant laxatives because this is a child who's got a full rectum and is usually it's either overflow or, more commonly in my experience, it's just the little bits of stool kind of coming out when the child is not paying attention. And if you can empty that rectum, keep it empty, then they'll do much better. And I would start with stimulant laxatives, although some of these kids may end up needing enemas.
So, Tim, why did so many people give enemas? And how would you distinguish between laxatives and enemas in this patient?
You know, I think based on whether they have the ability to actually be like fecally continent. So if it is a pseudo obstruction and you can kind of get them clean, then they should have the ability to be continent. So you can put them on laxatives, and those laxatives should work, and they can, you know, have the correct kind of stooling pattern. I think for us, or when I think about it, enemas may be reserved for the kids that either can't tolerate the laxatives, either due to the side effect profile, or they can't, you know, once again, they have true fecal incontinence. And then we would go to enemas with probably the further plan of having some type of procedure to allow them to give it antegrade, because, you know, what kid wants to get rectal enemas from their mom for the rest of their life, right?
Yeah,
So.
no, I mean, I think that's a good point. Again, to repeat Megan's point from earlier, are the sphincters intact? Is the dentally intact? And then, of course, what's the behavioral situation of the patient? What's the age of the patient? Did you want to add something to that?
I was going to add the length of the symptoms could be a factor in this. If this is a kid who's had obstruction for 5 or 6 years, it may be reasonable to start on an enema program and then plan to transition back over to laxatives after things have had a time to shrink, because there's some chronicity to that, and you can struggle.
It also, I think,
In-
if you, by using the enema program just to start with, you start giving them the sensation of full rectum, empty rectum, full rectum, which does part of the training that they need to relearn for stooling patterns.
Yeah, I think those are very valuable points. An enema program is not like a defeat, right? In fact, an enema program could get them very, very well and happy. And I like to say that I think it sets them up to future success with bowel control, because they've learned what it's like to be clean, even though you've done it artificially.
I know this is unusual, Mark, but I'd like to disagree with you on that.
Bring it, happy to.
So the problem with enemas is a lot of these kids, especially if they're 3 to 5, they're anally defensive. They are stool holders. And you know, stool holding is a common thing in normal children, but I think it's even more common in Hirschsprung's kids, because they have that tendency towards hard stools and chronic constipation. So if you start attacking them from below, it actually makes that stool holding worse. And so that's why I prefer to start with the stimulant laxatives. And if that doesn't work, sure, then you sometimes have to go to enemas. But
I think this is a discussion you have with these families. You figure out, is this one of those anally defensive kids that this is a no-go? Then you say, I'm going to try stimulant laxatives, and if we don't get there, then maybe we're going to have to go to an antegrade, because we know that's a no-go, but we'll give it a try.
Yeah.
And if we don't get where we want to be, then maybe we make a different decision.
And again, there are patients with Hirschsprungs that have behavioral issues, Downs, autism, etc., that do not have the mental capacity to have successful voluntary bowel movements at the age of 4. What do you do with that child? Rectal enemas are great. If they won't tolerate them, then we have other options like an antegrade enema. Don't forget, though, if you have a behavioral Hirschsprung's patient with perfectly normal sphincters and you do an antegrade enema on them, you got to Botox the sphincters, because their sphincters are so good that they will defeat your flush. They will hold in your antegrade flush.